come from a behavioral background, and as we know, until we really get a vaccine and people take that vaccine, we have to deal with COVID from the perspective of behaviors. And all the policies that we have at this moment in time are all behavioral-based policies. And ultimately, our success in managing COVID is going to be driven by our ability to engage people in that process and get them to adhere to these, help them adhere to these policies. But these policies come with significant costs. So there's always this constant balance of the cost of doing this versus the benefit. And ultimately, what we're trying to do within the context of iCARE is sort of understand what are some of those drivers and what are the elements that we can identify that will allow us to work out who the policies are working for, who they're not working for, and why. And using all of that, the goal is then to develop data-driven recommendations that we can feed to governments to optimize policies, and more importantly, probably communication strategies to really optimally engage as many people as possible. So the study's a large undertaking. It's a massive collaboration. We've got 158 collaborators from 40 countries. There's multiple components to this, but at the core of it is a survey. We've been fortunate enough to be able to translate that into 36 different languages. Pretty much I think about, there's about 4/5 of the world have access to this. It's also an ongoing project, and if people are interested in getting involved, you can just send me an email. We're always looking for new collaborators. But as I say, the study constructed of really 4 components. There's the survey itself, there's Johns Hopkins case data, Oxford policy data, and Google mobility data. And largely what we're trying to do is merge all of this, and I'll talk a little bit about that. The survey, at the core of it, it's a multi-wave cross-sectional survey. So what happens is we release a survey and we just keep pushing it out there. The core of it is a convenience sample. Though we do have representative sampling going on in parallel. So we already have a number of representative samples from Canada, UK, Ireland, Australia. And we're just about to instigate a Canadian longitudinal study. In terms of representation, we have all continents, and we are just about to get Antarctica on board. So we will actually be able to say all continents probably by next week. The survey itself, what's unique, so obviously there's been a huge explosion. I don't know how many people have had, goodness knows how many surveys come to them. I know I've answered a fair few. What's unique possibly about this particular survey is we've actually used behavioral frameworks to actually construct the elements of the study. So this is not random. And this is being constructed in a way where we can actually then leverage that information and put it into a behavioral context where we actually can do something about it. And at the core of it is what's called the COM-B model. Just to say, these are all the various different components. We cover a range of different aspects. At the core of it, though, is this COM-B model. So that's the capabilities, motivation, opportunities, and behavior. And you'll see the various different components on the left-hand side in the red boxes. The actual elements we capture, and this framework is constructed in a way to not only understand how the behavior occurs and all the drivers of that behavior, but then to also identify ways in which you can intervene on that behavior. So this gives us a really great opportunity to work out what we need to do to actually change the things that aren't working. This is a small bit out of date because we've just changed some of the schedules after September 15th, but we are currently in survey 5. So the core of each of these surveys has remained pretty consistent across time, but of course, as the pandemic has evolved, we've tried to evolve the questionnaire with it, and there have been small tweaks as we go. A good example is in the most recent survey, there's a much heavier emphasis around schools and school reopenings, because certainly in the Northern Hemisphere and to a large degree in some of the Southern Hemisphere, it coincided with that September opening. In totality, we're almost up to 67,000 responses to the survey. And I think when you look, it's about 143 unique countries that we have data from. And that varies. Some countries are great across all the surveys. We've got lots and lots of data. Other countries sort of ebb and flow. So there's some challenges there, but there's some great opportunities too. I just briefly mentioned the other data sources. So the Johns Hopkins, so most of you will probably be aware of this because this is the default that everybody falls back to when talking about what cases look like and various different countries, but they actually make their data publicly available, so we've imported that. Oxford University has been doing this policy tracker, so ever since the start of the pandemic, they've been able to track policy over time. And then Google Mobility is providing some information that you can download and access as well, which sort of maps on people's various different movement patterns. And so what this allows us to do is when we combine all of this, we have the policies, people's reported awareness, engagement, impacts, concerns, etc., around those policies. The Google Mobility data that provides a bit of a cross-reference to that, and then the outcomes data. So we can stitch all of this to really see what the pattern of policy to impact actually is. Now, as I said, there's lots of stuff going on. We have a place, a repository where we put all of the work that's going, and this is just a snapshot of some of the things. We have various different papers looking at different countries, cross-country comparisons, etc. What I'm going to do is I'm just going to highlight a couple of results because there's so much stuff in here, but these are a few things that I think are really just interesting. So one of the things has obviously been mask wearing, and we have a fair amount of Canadian data, so I'm just going to present some Canadian data here. This goes up till the end of summer, and but just is a nice contrast. When you look at Canada, you know, we're not a culture that particularly engages in mask wearing. So at the beginning of the pandemic, I think about 2% of all Canadians wore masks. Over time, that's picked up pace. Now, all of this data is before any of the actual formal mandates around mask wearing were in place. So this is just natural awareness of the change in patterns of the change in emphasis on mask wearing. Now, this is all of Canada with the exception of Quebec. And when you start looking at Quebec, this is what the data looks like. So very interestingly, Quebec was really slow off the mark and never really picked up until this really interesting moment around mid-May, where all of a sudden the pattern of mask wearing did change and it aligned with the rest of Canada. And what was that point, you ask? This was when Francois Legault did his first news conference wearing a mask. So one of the key things, so this is a classic technique in behavioral science of modeling. So people of importance demonstrating a behavior and sort of emphasizing the importance of wearing this. And it had a huge impact. And actually, when you break it down and look at the Quebec population and who in Quebec really picked up the pace, as it were, wearing masks, it tended to be non-urban areas, francophones, and a larger proportion of women. And when you look at the CAQ's voting base, it's very consistent with the CAQ voting base. So really there was a resonance there. So I'm not going to get into what's some of the negatives at this moment in time at this point, but you know, clearly this was a positive aspect, and certainly it contrasts to other countries where mask wearing has been a much more tricky scenario for the leaders. What we've tried to do very much, so the big challenge with a lot of this work is trying to pump it out as quickly as we can. And, you know, papers is one way, but also we've been very proactive in trying to get infographics and these snapshots out as much as possible. What's interesting is we've also, through this process, been able to look at some other data that doesn't actually necessarily require all aspects of what we're pulling upon. So I showed you some data based out of the survey. One of our subgroups is now looking at these questions around behaviors, COVID, and the flu. And there's some really interesting findings. So I'm just going to show you, this is a paper that's in progress, just about to be submitted. On this figure here, I'm just going to very briefly show you. So this darker blue line, the darker blue line shows you this current flu season in Canada. And the dotted line is the normal average pattern of flu season. The red line is COVID cases, and the black line is the point at which the measures came in to change to the instigation of all the various different behavioral measures and policies. So really what you notice here is that the flu, we lost about 6 to 8 weeks of flu. Flu normally comes around, this is weeks in the year. So this is, what is that? That's probably about April time. So it normally flattens out at April. We were about 6 weeks ahead of the curve. And, you know, you can see there's this huge impact. So unsurprisingly, people stop interacting, they wash their hands more often, they socially distance and so on. It really stops the spread of flu, as you would probably expect. It's an infectious disease. So that, you know, there's a positive side effect of that. However, what it does also highlight is the fact that clearly flu and COVID are nothing alike. And we know that the transmissibility of COVID is much worse than it is for flu. And this is a really great demonstration of it, because even when you can stop the spread of flu, you cannot tame the spread of COVID in the same way or to the same magnitude. So that's, you know, Canada. But what was really more interesting in this paper that we were doing was then comparing it to our collaborators in Australia. And that's because the timing of this is all offset. So this is where they introduced their behaviors. The dotted line, remember, is the normal pattern of flu. This is where they would normally see their main flu season, which is about now, just coming to the end now. And they hit a second wave. And because of all of the behaviors that are being put in place, this is their flu line at the bottom. So they pretty much annihilated their entire flu season this year. Once again, flu and COVID, very different. A final point to highlight from this is the importance of the fact that if they had a flu season at the same time as they'd had their second wave of COVID, they could have been in real problems because of the healthcare system being overburdened. And this is something that the Northern Hemisphere countries really need to take into account and really need to work hard to make sure that things like flu vaccines and so on get out there. Final things, my final slide in terms of data, just schools and community spread. This is data from Quebec. And what you see here, this is daily cases, rolling average. This is daily case in schools. Sorry, yellow line's daily cases in schools. This is daily cases in the community. Schools open. What you see here is about 2 weeks after schools open, a sudden increase in the rates of community spread. That's across the entire province. You look at that on a scale looking at Montreal. And what was unique about Montreal is obviously French schools opened, and then 1 week later, English schools opened. So 2 weeks after French schools open, you see a similar kind of inflection point. 1 week later, which coincides with 2 weeks after the English schools, all of a sudden you get this multiplicity effect and a ramping up. So I won't get into too much detail about the impacts of schools on community spread, but you know, there's some pretty interesting evidence, and we're working up some real analyses to demonstrate that rather than just visually. Final thing I'll say is as we've tried to push this out in a variety of different ways, we've hit a lot of social media. I like this slide because it gets me the opportunity to highlight Dr. Kim Lavoie, who's the co-PI on this project. And so really, this is actually Kim's the primary PI in this, and I'm the co-PI in reality. And just to finally say thank you to the team, I highlight Dr. Jovana Stojanovic, who is a postdoc in our lab and at Concordia, who's been phenomenal in this process as an epidemiologist and has bared the grunt work of most of this, and Vincent Gosselin-Boucher, who is a PhD student at UQAM. The two of them have really been at the core of so much of this stuff. And then our phenomenal staff. So Catherine Seguin leads this project on the staffing side. Ruth Bruno is our analyst. So with that, I just want to say thank you and take any questions.
Thank you very much, Simon. Very interesting talk. The last one I have was from Bill Hayden. Is there any truth that flu impacts Quebec more than the national average?
There is no evidence that the flu is any more virulent to Quebecers or in Quebec. it may be, you know, there's probably some cultural elements that impact how flu may spread more in Quebec. I mean, obviously, we have a greater tendency to kiss people on cheeks. We have a greater tendency to be generally more touchy-feely in Quebec than in other provinces. So those modes of transmission may be more likely.
Oh, yeah. Okay. Thank you. That's a very good answer. I was just wondering, with regards to the spread, I saw that in your graph, there was this sort of inflection point, like where it sort of went down in terms of school spread and then went back up. Can you go back to that slide if possible?
I can, just give me a second. There we go. So sorry, I'll go back. So this is rolling averages.
Okay.
So, you know, you've got natural fluctuations. If you do this as a cumulative, it just keeps growing and growing. And of course, this is a function of not just the number of schools, but the number of people in schools. So one thing I would say is that we're not getting huge amounts of in-school transmission. So for example, someone comes into a class and everyone in that class gets sick. What you're seeing is someone comes into the class and a handful of people within that class are getting sick. But what this sort of graph sort of identifies is the fact that those people are then going back into the community and helping to drive that community spread. So there's a complexity there. That you don't necessarily pick up in the nature of the school line there.
Okay, thank you very much for your answer. I have another question from Department Assistant. Why is there such an emphasis to get the flu vaccine if so many are self-isolating?
Yeah, that's a great question. I think it's really the issue here is the last thing we want to have is a natural flu season on top of COVID. So it's really a very preventative strategy. The Australian data I showed you, part of their strategy was really to make flu vaccination incredibly accessible. So they vaccinated more people than they've ever done in their history. And they did a whole bunch of novel things about really getting vaccines out into the community. So it's really that key preventative piece. The concern is our hospitals are going to be overwhelmed. They're almost at the point of being overwhelmed now. You map flu on top of that, and then you run into real issues, and you may see exaggerated negative outcomes because of the flu running in parallel.
So do you think that the Quebec government should be making the flu vaccine more readily available to just the general population? Because, you know, right now it's restricted to certain populations. They have expanded it somewhat, but not that much. So
yeah, I mean, I think everything and anything that can be done to decrease the impact of flu is going to be really important. So they're starting with the most high risk, which is appropriate, but they need to then go one step further and really expand that beyond.
Yeah. So I'm going to do this one last question. Great talk, Simon. Can you elaborate on how you will integrate the Johns Hopkins, Oxford, and Google data? I assume you will be linking people via geographic location. What are some of the hypotheses? Sounds fascinating.
Yeah. So so people are linked based on geography and date. So it's not a straightforward process, but effectively, and geography can go down to multiple levels. So at the very minimum, it's a country level, but if we've got the capacity to go beyond that, we go beyond that. So Johns Hopkins will give us state level and province level data. So we've been able to link at that level too. And so then the what we're trying to identify ultimately here is which of the policies are working and who are they working in. So that's number one, right? And broadly, which policies are universally good. Then a secondary element that spins off of that, which is probably the most important aspect, is who aren't these working in, and then how would you change those policies, or how would you communicate those policies differently to those populaces to engage them? And one very brief example is we know that at this point in time, the people that are less likely to be doing social distancing, hand washing, and mask wearing are generally the younger population and males. And when you look at what their concerns are, because we have that data, their concerns are primarily economic concerns. Yet all the rhetoric that comes out from the government and what the government pushes constantly is health. So their health messaging is having zero impact in these people because they don't care about health. So a direct outcome from what we've been trying to push is to feed governments information that you should change your messaging, structure the question around, if you were to engage in these behaviors, here's how you would actually get the economy back going faster. Here's how job opportunities would increase. And if you actually package the messaging around the policy that way, you're going to have a much greater probability of them being able to get those people re-engaged in that process.
Okay, thank you very much.